Hey, good morning, everyone. Let me know if you can hear me okay. One. Hello. All right, you should be able to hear me now. Sorry about that. Yeah, so I think we left off on this slide, but if anyone can remind me if it's a different one, let me know. Mute button's been kind of acting funny. Perfect. Anyone know what slide we left off on? Well, I'll just start here, because I think we got through the pathophysiology and whatnot. It looks like the quiz went okay, so 2 people are still taking it. I have on my slides. Okay, do that. Perfect. I'll do that. Yeah, quiz overall looks pretty good. So normally what I'll do is I'll take a look at the stats on there and see if there's any questions that are look off. And then I'll see if there's any high misses, and we can talk about that. If you have any questions, you can post them up here. Start about so actually 5 seconds. How about that? Put down my Dropbox. That messes things up a bit. Okay. Alrighty. Well, thank you all for joining me here today. Hopefully the quiz went okay for you all. The grades just at first glance look pretty good, so I'm gonna say that that was a success. Fortunately, didn't seem like there were too many technical hiccups, so that's good. How would you treat an Ultram overdose? That's a great question. So with Ultram overdoses, because it's a partial opioid agonist, it does somewhat respond to naloxone. So if they were like sedate, if they had respiratory depression, you can try out some naloxone. One of the other big things you can actually find with Ultram is it can cause seizures due to its norepinephrine and serotonin reuptake inhibiting effects, and so you can actually end up finding the seizures you have to manage with benzodiazepines, which is another class of drugs we'll get into in the neurology section, depending on how quickly we can get into that today. But anyway, so getting into, of course, pop up any questions in the chat or on the sticky board if you like. But anyway, so we were talking about rheumatoid arthritis and osteoarthritis. Just kind of going through the path of phys last week, so hopefully that's still somewhat fresh in your mind. Just to recall, in terms of our goals, what we're shooting for here is we want to make sure that we are dealing with like kind of any acute pain issues they're dealing with. Try to make sure that if we can help out with their functional capabilities, so for instance, being able to get up and go to work, such that they're not in such pain that they can't do that, or pick up their grandkids or whatever the case may be. And then for RA, the other big thing is you'll find with these autoimmune conditions, they can have periods of flare-ups and then remission. We want to get them back into remission and then hopefully slow down disease progression. Make sure that we try to limit the amount of joint deformity that happens over the long haul here. So that's mainly what we're going to be shooting for. In terms of joint, or in terms of non-pharmacologic therapy, we have a lot of things that we can utilize here, and these are critical. You have to initiate these along with the pharmacologic stuff because they're so synergistic, and it's oftentimes very difficult for a lot of patients because it's hard work, and things like physical and occupational therapy. It's easier to take a pill that makes me feel better than it is to actually get out there and start doing exercises and things like that. But you as PAs are going to be kind of critical in that component of making sure that they can be compliant with that stuff. Weight loss is huge with osteoarthritis too. It takes a lot of pressure off of those joints, which can be helpful. And certainly things like surgery may have limited to no utility for rheumatoid arthritis, but certainly for osteoarthritis. Knee, hip replacement can also be somewhat definitive therapy for those patients as well. So anyway, looking at general treatment here, we're going to find for RA, because that disease is inflammatory in nature, that you're going to use a lot of anti-inflammatories, things like corticosteroids, things like NSAIDs. We're also going to get into our DMARDs, which stands for those disease-modifying anti-rheumatic drugs. That's going to be the thing that slows down progression and prevents kind of progressive joint damage. For osteoarthritis, we're going to see that you still use some anti-inflammatories, but notice there's not a lot of use of corticosteroids on that side of the slide. Still may use NSAIDs occasionally. Sometimes opioids are utilized, hopefully pretty sparingly, but for the most part, you're going to see very limited use of corticosteroids, unless it's for like an intra-articular injection, which we'll talk about briefly here. Anyway. So for the DMARDs here, that stands for disease-modifying anti-rheumatic drug. They get broken down into two main categories, biologic and non-biologic. You may hear me use the term traditional for the non-biologics because they're sort of the oldest ones, the ones we've had around for quite some time. The biologics, that just means they're going to be protein-based. They're going to be, antibodies that we've developed, things like that we're going to be utilizing for these patients here. And these are critical. You got to start something for these patients here in the DMARD category, because even if it doesn't relieve acute issues of pain and discomfort, they will slow down disease progression in the long term. So these have to be on board. For more immediate relief of symptoms, that's where you get into like your NSAIDs and your corticosteroids. Again, we're going to try to limit how many corticosteroids we need for these patients. However, for a lot of them, you're going to see they're going to need to be on low dose prednisone or something like that, for the foreseeable future in some cases. I'm not going to list every single one of these DMARDs that are out there. These are the most common traditional ones, and then certainly for the biologics, I'm only going to cover a sort of a sampling of them. There are so many new ones that are coming out because it's really sort of a a blockbuster set of drugs that are coming out. There are always new ones coming out. A lot of drugs that have similar activities, but they have their own unique patent on it, and it's a big money maker for a lot of these companies. So that's why there's so many of them out there. I'm going to cover just the main ones though. For traditionals, we have things like Methotrexate, Hydroxychloroquine, Sulfasalazine, and then Leflunomide. And we've already talked about Methotrexate, I know, back in the oncology section. I was just checking to make sure we did that last semester. I think we did. For the biologics, I'm going to have a couple that are on here. If I don't mention them, if I don't go into more detail on them in future slides, then don't worry about them. I'm just kind of listing them here. But we'll find that we'll be breaking these down into their individual targets in terms of what they're going to be binding to. So we'll have the anti-TNF drugs. The main ones I'm going to talk about are likely going to be Infliximab, etanercept, and then adalimumab or Humira. Those are probably the three big ones I'm going to focus on in the individual slides. A different mechanism can be what we call a co-stimulation modulator, abatacept. And then we'll have, and actually there's an error on this slide here. I need to fix this. So hopefully you guys will, I apologize. This is going to be a CD20 antagonist. Uh-oh. It's funny, my slides like to change around based on the numbers I hit, so sorry about that. Anyway, so there's an error on the slide. You can correct that. But in terms of IL-6 antagonists, we'll have Tocilizumab. We'll have a CD20 antagonist, which will be our Rituximab. And then actually a new class of drugs. This is relatively new in the grand scheme of things, called the JAK inhibitors. This will be Tofacitinib. So this is kind of the newest, latest and greatest sort of thing here, and it's got some novel effects and some unique benefits we'll get into here in just a little bit. There's a lot of other ones that have been used out there in the past. I'm not going to get into great detail on a lot of these. You know, they have varying efficacies and toxicities, but these have mostly gone by the wayside just due to the increased efficacy and safety profile of a lot of the traditional ones I mentioned, the biologics I mentioned. But you still may see these used occasionally for more difficult to treat cases. And you hear gold, you're like, well, why the heck would you use gold? You know, gold's a heavy metal. It can have some inflammatory effects by basically poisoning your immune cells. And so fortunately we don't use that anymore because it's also pretty toxic to a lot of your normal cells. Also, you know, it's, patients have to have really good insurance to get a hold of it. Not really, but yeah, not a great set of drugs. Anyway, so generally speaking, we're going to find that the overall mechanism, we may know like kind of at a baseline what the drug does, but in terms of how it works to slow down progression of disease in these patients, we may not really have the full details on that. In general, most patients are going to start out on methotrexate and or hydroxychloroquine. Hydroxychloroquine should kind of sound familiar to you if you've been keeping up with any of the news in the past year. That was touted as a potential drug for COVID, but we're going to talk about it here in terms of its use as an anti-rheumatic sort of drug here. Most patients are going to start out on methotrexate just because it's like we've had it around for decades. We know how it works. We know it works pretty well, and safety profile is pretty good for the most part. And you can see here, just with use of methotrexate and corticosteroids, you know, most patients, you know, over 50% are able to stay just on that combo for, you know, more than 5 years. But in some cases, you may need to combine multiples, and we'll talk about how we do that and sort of the logic behind mix and matching these different DMARDs here. So as I mentioned, should be started methotrexate for most patients with RA just because we have good long-term data here. And it also can serve as sort of a backbone for multi-drug regimens. So if we need to use methotrexate plus something else, you have a lot of options when you do that, which is nice. Another thing to consider is a lot of the traditional DMARDs take time to kick in. So, you know, between like 3 and 6 months to really to have their full effects. Some of them will have a little bit faster onset, so things like methotrexate, leflunomide, sulfasalazine, about 1 to 2 months or so. That can also be a benefit. And frequently, during this lag time before the drugs really kick in, you're utilizing things such as corticosteroids to sort of bridge the gap in terms of symptomatic relief for those patients there. Biologics, they tend to work a little bit faster because they have sort of direct action right there on the different, you know, inflammatory cytokines and whatnot that they're affecting. Sorry, I feel like I have a sneeze coming on. I don't want to sneeze right in your ears. No, it went away. Apparently, if you think about it too hard, the sneeze goes away. And so, anyway, the biologics tend to kick in much quicker. So that is one benefit to those drugs there. And another thing to consider is all of these drugs are immunosuppressive, right? Just by the nature of their activity here. So you want to make sure, especially with the biologics, that you're going to be testing for TB beforehand. because if they have a latent TB infection, it can potentially activate, and then now you have active TB in a patient who you have to treat that while they're immunosuppressed. Not great. This is probably going to be a part of the typical workup for these patients anyway when they get diagnosed with rheumatoid arthritis, so hopefully that will be checked already. And hopefully all your vaccinations are up to date before getting the before getting any of these immunosuppressive drugs. So to get into that specifically, basically, when you talk about vaccines, and I might go into this in some more detail in a later point in this semester, but vaccines can have different varieties and types of vaccines. One of the main categories is called live attenuated vaccines. Basically, it's a version of a virus or a bacteria that has been made. Basically, it's kind of making it pretty wimpy. It's kind of neutering it, so to speak, such that when you give it to a typically healthy patient, the patient will be able to develop a normal immune response to it, but the disease is so wimpy it can't cause the disease in question, right? So for instance, there's a version of the flu vaccine. If you get like the intranasal flu vaccine, for instance, that is an example of a live vaccine, right? It's a live attenuated vaccine. On the other hand, though, you can have what we call killed or recombinant vaccines. Those are typically going to be basically dead versions of the virus or the bacteria, or a portion of the virus or bacteria that is unable to replicate on its own, is unable to cause disease on its own, but your body can still react to it and you can get an immune response, okay? So anyway, point being is that when they're on immunosuppressive therapy, they can get a killed vaccine, no problem, because the bacteria virus, it can't replicate because it's dead, right? A dead thing can't replicate for the most part. So this can include things like your pneumococcal, IM flu shots, hepatitis B, etc. You don't want to give live vaccines to these patients because there's a possibility, because they're immunosuppressed, that virus or bacteria can start to replicate on its own, and it can actually cause disease in those patients, okay? So live vaccines are not good for patients, especially taking the biologicals, but really any immunosuppressives, you probably want to be hesitant. So the idea would be to take any live vaccines prior to starting any of these DMARD therapies. If you have to get a live vaccine while they're on it, sometimes we have to discontinue the DMARDs and then give them the vaccine. But they're okay to get the killed or recombinant form. That's totally fine. There may be decreased efficacy because they can't mount as good of an immune response against it. But again, that's kind of a trade-off you're going to have to take there. So just something to consider with that. And even sometimes you'll find that recommendations for vaccines may change based on if they're on this DMARD therapy. So for instance, they may recommend getting the herpes zoster vaccine earlier than normal because of this sort of chronically immunosuppressed state these patients are going to be in, right? So that doesn't make sense, let me know, and I can go into more details on that. Okay, so first off, let's talk about methotrexate. This is basically, we talked about this before, this is a drug used to inhibit the actions of folic acid. It prevents your immune cells from utilizing folic acid and the formation of new nucleotides and new DNA, such that your immune cells are not able to replicate as well, okay? So, and keep in mind, the use of this drug is different for rheumatoid arthritis than you would see for chemo, right, for oncology. The doses are far different because with leukemia, I'm trying to wipe out all of your immune cells because they're cancerous and I want them to stop growing. In this case here, I just really want to kind of tamp down the immune system, just kind of chill it out. So you're using oftentimes much lower doses of methotrexate, and so the side effect profile is going to be much milder as well. Same risks are associated with it, but they're just in a more mild sort of form, as we're going to see here. But remember, just know that this drug is inhibiting the utilization of folic acid, can't produce new DNA, and thus your immune cells are not going to be able to replicate as well. Okay. Again, just a picture showing you how we have this recycling of folic acid that occurs here, in the use of things like thymidylate synthase and other enzymes used to make new nucleotides. And you can kind of see how methotrexate looks pretty similar to tetrahydrofolate and basically inhibits this process here. If you recall, the way to get around this is to use the active form of folic acid, which is called folinic acid or leucovorin. But usually we don't have to use that too much for these patients here with RA. Okay. With this, in terms of toxicity, it's all the same stuff we've seen before. So all of your rapidly dividing cells are going to take a hit here, meaning you can get bone marrow suppression, meaning thrombocytopenia, leukopenia. You can have the GI cells taking a hit here. So you can see things like GI and oral ulcerations. Hepatotoxicity is something you definitely want to monitor for in these patients. Alopecia, pulmonary fibrosis, again, less likely to occur with these smaller doses, but over the long term, who knows? So that's why you want to monitor for it. You also have to watch renal function for these patients here. If they are not able to clear the methotrexate, it will accumulate, and that's going to lead to much greater side effects here. So typically, if patients have chronic liver disease, if they have renal insufficiency, methotrexate may not be a good drug for them. Okay, so those are things you want to look for. Also, this should not be used for pregnant patients because if you can think of anyone that has a lot of rapidly dividing cells, it's probably a fetus. And so this has actually been used as an abortifacient before. I think last semester we talked about the drug misoprostol being a prostaglandin. It was also an abortifacient. So methotrexate plus misoprostol has been used in the past to induce an abortion. So just to give you that kind of context, this would be a category X drug. You would not want to use this in any pregnant patient. So if they have a patient of childbearing potential, then you may want to consider things like contraception and whether or not that's going to be necessary for your patient. Anyway, so methotrexate is going to be the most commonly used DMARD that's out there. As I mentioned, it has relatively rapid onset of action and pretty acceptable incidence of adverse effects. You're going to find, again, that you're using relatively low doses of this as compared to cancer. Patients can take it in a variety of ways. I see some people that will get this as a sub-Q injection that they do at home once weekly sometimes. They can take it orally every day. It really just depends. And remember, your monitoring parameters here include CBC, because you're looking for the white count and the platelets, LFTs, serum creatinine, all of that. And typically, you're going to monitor it more often at first, and then you can kind of scale that back down as they sort of stabilize, and you kind of see that they're going to do okay with the drug. In some cases, we'll go ahead and recommend folic acid. Either they can get like a once weekly dose of 7 milligrams or 1 milligram a day. Again, this is trying to kind of help decrease some toxicities for your kind of other healthy cells. Again, I don't know the full utility of this. There's probably not a lot of good evidence necessarily, but folic acid, it's just gonna be a necessary vitamin anyway, so it's probably not gonna hurt anything to get a little extra on there. All right. Next up, we have leflunomide or Arava. This is going to be inhibiting pyrimidine synthesis, so similar sort of in action to methotrexate to a degree, although just the mechanism is a little different here. It's not working against folic acid. This is actually a prodrug that gets turned into another compound called teriflunomide. So there's a drug used for MS called teriflunomide, so these are very much related there. But overall, you're going to see that the efficacy here is pretty similar to methotrexate. You're going to see decreased symptoms, inflammation, and the onset's pretty quick here. So if you had a patient, for instance, who couldn't get methotrexate for the reason they have depressed kidney function, this may be a good alternative for them as a potential substitution. In terms of adverse effects, again, GI stuff you're primarily going to see, but the most significant things are going to be the immunosuppression, hematologic toxicity, right? So you're looking at that CBC. And this one can still cause some hepatotoxicity. So again, if they have poor kidney function, this may be a good drug to use, but they have, hepatotoxicity or chronic, liver disease, this may not be a good option for them. The other interesting thing too is that yes, this drug is also teratogenic, meaning just like methotrexate is, meaning it can cause death or destruction of a fetus, or congenital birth defects and things like that. What's interesting here is that it undergoes what we call enterohepatic recirculation. I probably mentioned this before. It's a cycle where this drug will be eliminated through the biliary tract. It can then be reabsorbed from the GI tract, and it extends the half-life of the drug because it undergoes this cycling. It doesn't get eliminated through the feces because it keeps getting reabsorbed. So what's interesting is even if the patient stops taking it cold turkey one day, you can find levels of the leflunomide for like months after the fact, or the active metabolite like months after the fact. So if you had a patient who wanted to become pregnant, they might be waiting for a long time for that to be a safe option for them. And so sometimes what they'll do is called a cholestyramine washout, where they're going to take the bile acid sequestering cholestyramine, and that will bind it up in the GI tract and help to eliminate in the feces faster, and thus hopefully get down to negligible levels, so that way the patient could potentially become pregnant if that is a goal of theirs. Next we have hydroxychloroquine. This is probably going to be the wimpiest out of the DMARDs we're going to look at, but it's also the best in terms of side effects. So it's kind of the trade-off you get with that. So less efficacy, but less side effects. And so you'll see this sometimes used by itself for really mild disease. Sometimes you'll see it used in combo with other things. So you could do like methotrexate plus hydroxychloroquine as an example there. In terms of its mechanism, the reason why it's not as immunosuppressive, it kind of makes sense because it doesn't really, inhibit the replication of immune cells. As you can see here, it basically prevents a lot of the immune cells from getting to the site of action, right? The joints actually cause inflammation. So if it's inhibiting neutrophils and other cells from getting to that site of inflammation, then they can't cause the inflammation in the first place. This one's going to have a little bit slower response time, usually about 2 to 4 months or so. And so there's less monitoring associated with it as well, because there's no myelosuppression, no hepatotoxicity, etc. So again, wimpy in terms of activity, but also pretty well tolerated. In terms of other things we want to look for, monitoring includes visual acuity. You can see some retinopathies that can develop here, so you would want to watch for that over the long haul. And then you can see some dermatologic reactions like rash and whatnot, and then this kind of increased skin pigmentation, which you can see on this patient here. It's kind of grayish skin discoloration. Another drug you may see used for things like ulcerative colitis or Crohn's is called sulfasalazine. This is an oral product that will be cleaved by colonic bacteria. Again, all these traditional DMARDs we've seen so far have oral options that are available, so that does help with compliance. That's not going to be the case with the biologics, as we'll see. And so this gets broken down to a product called sulfapyridine and then 5-aminosalicylic acid. We already talked about NSAIDs previously, and so it makes sense that this 5-ASA to salicylate should have anti-inflammatory actions just like aspirin does, right? So it's also thought to help out by doing things like, scavenging free radicals, so that helps to prevent some damage to, the cartilage and DNA and things like that, or the other, proteins within the joint. So some activity here, some limited utility, but fast onset of action. Usually within a month or so, you should start to see some benefits here. This probably won't be like a go-to drug, but certainly you may find some patients may use this as like an add-on potentially here. Mainly because a lot of patients do develop some degree of side effects. This is limited by starting at relatively low doses and kind of titrating up, and then you treat supportively, right? So if they're having nausea, vomiting, maybe use something like some Zofran, for occasional nausea, vomiting, see how that works for them. One of the benefits here is that you're not going to see a lot of significant immunosuppression, so you don't have to worry about necessarily monitoring the CBC so closely here. Or if you were to use this in addition to something like methotrexate, you're not going to see too big of a jump in myelosuppression as you would see if you used leflunomide plus methotrexate as an example. You will see a lot of drug interactions here, including like antibiotics can be bound up in the GI tract here. Iron supplements can bind up the sulfasalazine. And you can also see some warfarin interactions where they're kind of competing for the same binding sites that could lead to an increased effect of warfarin. Just some examples. And then this does turn the urine and stools yellow or to orange. So of course, warn your patients about that. They may think they're bleeding or something if all of a sudden their pee turns orange. That would be certainly disconcerting to me if I was not warned about that beforehand. All right, so to kind of bridge the gap between the traditionals to the biologics, we have this new category of drug here called the JAK inhibitors. And so there's been a few other ones that have come out recently, but I just want to kind of focus on the first one out of the category because this one's probably the most common one you're going to run into. And this is called Tofacitinib or Xeljanz. So basically, if you recall back when we had our intro to pharm lectures in the summer, we talked about different types of receptors, and there's some called the tyrosine kinase receptors, and they're responsible for a lot of like cellular growth signals and things like that. And you can see here the receptors that will be bound by things like interferon and interleukin 2. When they get activated, they cause all kinds of downstream cell signals that'll lead to changes in gene transcription. So they'll lead to more inflammatory cytokines being made. Maybe they signal cell replication, all kinds of things that increase inflammation. Basically, tofacitinib is going to be inhibiting this process here by inhibiting these JAK proteins. It's going to have pretty good immunosuppressive actions in terms of preventing inflammation in the joints. And so we're starting to see this being used for more moderate to severe RA, especially in patients who have maybe failed initial therapy with things like methotrexate. And so you can see here, JAK just stands for that Janus kinase. You know, you need to remember that specifically, but just know it's a JAK inhibitor. And by disrupting this, you're going to decrease the cell signaling that's going to cause its increase in transcription of inflammatory genes. Okay. I guess inflammatory genes, is that where you lie and your pants are on fire? I don't really know, but just a odd musing I have while giving this lecture. So the benefit with this drug is that it's, you know, pretty effective for more moderate to severe cases of RA, but it's also available orally. And so this is going to be something that you were not going to see with the biologic. So it was kind of the case for a while where, you know, you'd use methotrexate for a while, see how it works. But if you had to, you know, kind of step up your game, you'd have to go with the biologics. But all those are injectable products, and that's not always ideal for your patients from a compliance standpoint. And so this was nice because it is an orally available drug. So that is one benefit to this. You can use it by itself. You can use it in combination with other DMARDs. One caveat here is you do not want to use this with other biologic agents. The degree of immunosuppression you get would be too great, and the risk for other secondary infections would be too high. Okay, and so I have a whole couple of slides later talking about mix and matching these drugs here. But in general, you know, I could do methotrexate plus tofacitinib. That makes sense. I would not use tofacitinib plus the biologics we're going to look at here in a slide or two. Okay. Do you know that this is a substrate for CYP3A4? So if you had an inhibitor on board, say something like erythromycin, this could lead to increased effects of the tofacitinib. So you would want to be cautious with that. And then you do want to look for hepatic and renal function, because we do have to consider decreasing our dose if that is present there. This is another one we definitely want to check for TB beforehand to make sure we're not going to lead to activation of a latent case there. In terms of big warnings you worry about this, you know, this certainly includes things like serious infections. Makes sense because we know it's immunosuppressive. And there's some risk for things like lymphomas and other malignancies. Again, low risk, but it is something they've at least noted, you know, in clinical use. And so it would be something you want to monitor for. Okay. So then getting into the biologic specifically, remember these are going to be protein-based products. So these are going to be very effective. However, they are pretty expensive. I'll have a few price tags on there to see. These are not the most expensive drugs that are out there. However, they are still fairly expensive. I think the king of all expensive drugs is still a drug we use for a pediatric condition called SMA, or spinal muscular atrophy. And it's a single dose drug. And I believe it's $2 million for that single dose. That's the most expensive drug. So, but anyway, the benefit to these agents is that they don't really suppress replication of immune cells. So there's like very little monitoring. You don't see the thrombocytopenia, leukopenia. You don't have to worry about liver dysfunction or renal dysfunction. These are very well tolerated for the most part. But you still have to worry about risk for infection because they are still suppressing the immune system. Definitely want to check for TB before starting therapy here. Some cases you may decide to discontinue once the patient has an infection that develops. Certainly you don't want to keep giving them that if they're having an active infection like pneumonia or something, because they won't be able to fight it off too well. And then, like we mentioned before, don't give live vaccines. You can still give a killed or an inactivated vaccine, but just know that it may not be quite as effective, but you can still give it. Lives, don't want to give it to them because there's a chance they will have the actual infection occur. So the first I want to talk about is going to be the TNF alpha inhibitors. I'm just going to give you a kind of a random smattering, or at least the ones I see most commonly. And so TNF alpha is going to be the first target here. These are going to be antibodies that are designed to target specifically TNF alpha. It's going to bind it up, neutralize it, and prevent it from causing increased inflammation by activating all these other immune cells, right? So all these in this category are going to have similar side effects and contraindications. So you can kind of all lump them together. And you'll see just in general, the biologics have pretty similar sort of side effect profiles here. First off, one thing that's kind of unique to the TNF alpha inhibitors is this idea of patients with CHF can have sort of worsened effects and can have exacerbations as a result of this. So we do probably want to avoid this in patients who have low EFs, or if they have more advanced heart failure, like, you know, class 3 or 4, probably want to avoid the TNF alpha inhibitors. And then for patients with multiple sclerosis, they've found some cases where actually they've had kind of induced flare-ups of their symptoms or exacerbated symptoms. And so in this case here, this would be a relative contraindication. Probably just watch it, and if it did happen, probably just discontinue the drug overall. And then some small risk for lymphoproliferative cancer, so certainly something you want to monitor for over time. So the first one we have here is called etanercept or Enbrel. This one's kind of interesting because instead of being the traditional monoclonal antibody we think of, this is actually basically two TNF receptors linked together at the Fc portion of a normal IgG antibody. So basically this is what the receptors would look like, and it sort of acts as sort of a trap for the TNF alpha. It'll bind to it. TNF alpha thinks it's doing its thing, but really it's bound to this this etanercept molecule, and it's inactivated. It's not able to go and then cause inflammation down the line there. Once this occurs, then the normal complement system can be activated, and that will get rid of that TNF alpha. So pretty neat kind of design from that standpoint. With the biologics, you can certainly use them with other traditional DMARDs. So you may have a patient who, for instance, starts out on methotrexate. Maybe they're not really like super well controlled, so then they add on something like etanercept as an example, right? So then you get additional benefits from that. We'll also look at some side benefits of doing that combo as well here in just a little bit. But generally, your biologics are going to be sort of a second line sort of DMARD. If you can get away with using oral methotrexate, that's ideal because it's cheap, relatively simple. But if you need some additional benefit, you can add something like this on. Notice here that a lot of these these biologic products, they have decently long half-lives, so you may see that you only have to give them once every 8 weeks in some cases, or in this case here, just twice a week. So that can be a benefit from compliance standpoint. But here, this would be like an injection they would have to give at home. So you have to teach them proper technique and make sure they're keeping their sites clean and all of that, because otherwise they could get skin infections. And just give an idea, $15,000 a year just for this one medication, in addition to all the other stuff they're getting, in addition to doctor's visits and everything else. So it's just, another added cost here. And I'm sure most people would rather, hold on to $15,000 a year if they could. So hopefully they have some kind of insurance coverage to help with this. Next, we have Infliximab or Remicade. This is one we use a lot. And again, I don't see a ton of adult RA personally, because I work in pediatrics primarily, but certainly we do have kids who have juvenile rheumatoid arthritis, and so we do certainly see a lot of use of these medications here. Either they're coming into the hospital because they're having an exacerbation, or more often they're coming into our infusion center and getting infusions of these medications. So I see a ton of Remicade being used for these kids all the time. Note here that when you form these monoclonal antibodies that, and I've probably mentioned this before, usually they will have some human protein, but there's also the chance that it has some mouse protein as well, murine protein. Again, the reason why and it's not like we're, harvesting a bunch of mice and getting their proteins and adding it into this drug here, right? It's like the amino acid sequence is derived from this mouse protein. But basically, this is an antibody that combines the two together. We call this a chimeric antibody. You can kind of see that with the X in the name here. It stands for chimera because they're crossing the two types of protein together. The reason why I mention this, other than I think it's kind of cool that we can utilize that, is the fact that, your patients may want, some extra cheese as a result of this. I'm just kidding. They usually don't. However, the problem is that because you're introducing mouse protein into the body, the chances for having a reaction to the drug is higher, right? So anaphylaxis, anaphylactoid reactions, that is a concern. If it's more human protein, or we call that a humanized antibody, that risk is lower, okay? So what does that matter clinically for you? Well, it matters because it may change where they're getting this drug. Meaning, if I have something like Infliximab and I have a decently high chance for a patient to have infusion-related reactions or anaphylaxis, I'm going to want them to get this in a place where I can watch them. So this is why we bring patients into the infusion center to get this. And they may need it every couple of weeks at first, but then eventually they may be like every 8 weeks or so they can get this. So it is disruptive to their life, but it is, something where hopefully it'll be minimally disruptive once they get sort of under control. Also, why this is not our first line, right? If we can add this on as sort of second line, if methotrexate is not really cutting the cheese, so to speak. I guess it's not really cutting the mustard. I guess it's the more appropriate term, but since we're talking about mice, cutting the cheese is something else, and we shouldn't talk about that. Anyway, though, so point being is that this is usually a good second line agent and add-on agent. What's also kind of cool is that using the combo of methotrexate plus infliximab is that, not only is your body at risk for causing anaphylaxis against this drug itself, but over time, not even anaphylaxis, but your body can develop antibodies that just neutralizes the infliximab, right? Almost like getting a vaccine makes you have antibodies against certain pathogens. Your body can do the same thing here. The point being is that over time, patients can lose efficacy of the infliximab because they develop antibodies against it. Methotrexate, because it's immunosuppressive, prevents that from occurring. So by using this combo, you can keep the drug active for longer, and that's overall good for your patient because they may be living with this for life in some cases, right? So we also find that there's a lot of infusion-related reactions with antibodies like this that can mean fevers, chills, myalgias, all of that. And so frequently what we're going to do with these patients is we're going to pre-medicate. So especially with these chimeric proteins, we'll see this again with rituximab later, it's another X in the name, that we're going to pre-treat. Usually we're going to give acetaminophen for the kind of chills and fever. We're going to give usually something like Benadryl in a lot of cases to help out with any kind of histamine-related reactions. And then frequently they're going to get corticosteroids in addition to that. So like if just a typical patient of coming in to our infusion center to get infliximab, they'll get a dose of methylprednisolone for the corticosteroid. They'll get Tylenol, Benadryl prior to getting the infliximab. They'll get the infliximab infusion after that. And then if they have any reactions, they'll have standing orders that have been written by the PA or the NP that will be for PRN anaphylaxis meds. That includes epinephrine, more corticosteroids, Benadryl, etc. So pre-treatment is really important for these drugs, especially the more foreign protein you're injecting, the more likely they are to have those infusion reactions. So again, just to give you an idea what this looks like in terms of dosing, again, they start off at 2 weeks, 6 weeks, and then you can do every 8 weeks thereafter. So the half-life is fairly long, and that's why you can give it so infrequently, which is beneficial. As again, just to also decrease those infusion reactions, you can also infuse it over a long period of time. So something like 2 hours will give this. Some patients have such bad reactions, we have to do over 4 hours. But again, remember how we're going to manage those. So just like I mentioned a second ago there. And of course, watch out for your risk for infections, right? Another one, so this one's going to be more humanized protein. So the U there is a human, I guess. And so this one you have Humira. This one's kind of beneficial because its likelihood of causing allergies and infusion risk, fusion reactions are much, much lower because there's no mouse protein here, so to speak. And so because of that, this is something patients can give themselves at home, right? So this is something you may see where they'll have pre-filled syringes or pens, basically, that the patients can put a needle on and inject sub-Q at home. So this kind of negates them having to come into the infusion center altogether. So that could be a benefit from a sort of, just life scheduling sort of situation there. But it does the same thing. It's just a different antibody, but it still binds to TNF alpha. It does the same thing as infliximab would do, right? Again, similar, side effects to worry about, injection site reactions, black box warning for those increased infections. All that's very, very similar in terms of its use. So it's a matter of just saying, okay, which one is the patient prefer? Did infliximab work for them or not? Maybe they can switch to Humira. Typically, if they fail one of these TNF alpha inhibitors, you're going to want to go with a different mechanism, but sometimes I've seen people switch. Maybe they don't like coming into the infusion center, so then they switch them to Humira because they had insurance that would cover it. Different things that go into these decisions here. So switching mechanisms, getting into one called abatacept or Orencia. This is for more moderate to severe cases, and this is typically used if a patient has failed a TNF alpha inhibitor. So if you're going to go with the biologic, TNF alpha blockers are first, then you're probably going to go with one of these other ones here. So in this case, we have abatacept, and it basically prevents this reaction between these two CD receptors, CD80 and CD86. And this is an important reaction when you're having these antigen-presenting cells trying to activate T cells. If you can block that, then you can block the ability for those T cells to be activated, and there you go. You have less inflammation going on. Again, very similar reactions you're going to see with the other TNF alpha blockers. Notice here there's no risk from the CHF exacerbation, so that could be one benefit. Maybe instead of using infliximab, first-line biologic for someone with rheumatoid arthritis and CHF, maybe this could be a decent alternative. So something to consider. Rituximab is another one, and you'll see this used occasionally for different types of leukemia. for oncology purposes, but we use this here as well for different rheumatologic conditions. This is another chimeric antibody. This one is pretty notorious for causing a lot of infusion reactions, probably even more so than Remicade. So I see that whenever we give this, we're always really concerned about that. So we're definitely going to pre-treat with the methylprednisolone, Benadryl, Tylenol at the very least. You'll get this and then infuse it over a pretty long period of time, usually 2 or more hours there. So you have to pre-treat it because of that. And again, you can use it along with other traditional DMARDs. You do not want to use 2 biologics. So I would never use rituximab plus Infliximab as an example, right? Because again, it's too much immunosuppression. This one's mechanism here is going to be against the CD20 protein on those B lymphocytes. So that's, again, a different mechanism. So if someone failed Humira, this may be something you'd want to switch them to, or something to try at the very least, right? So again, it's used in oncology, different rheumatologic conditions, main places you'll see rituximab being used. Tocilizumab is the first one here that's going to be an IL-6 inhibitor. So this is going to be interleukin-6 we're dealing with. I've seen a lot of good use here. I've seen some of our rheumatologists really like this drug for patients who may have not tolerated Humira or Infliximab very well. So I've seen a lot of people switch over to this. Some unique reactions here. It can cause some issues in terms of lipid effects. So if they had hyperlipidemia, this may be worsen some rare cases of GI perforation, which is kind of unique. That was interesting. But this also induces 3A4. So that's important because a lot of drugs are going to have reduced levels because you're suppressing you're increasing the activity of 3A4, so you're going to be more likely to metabolize these drugs here. So let me give you a clinical example. Imagine you had someone who had juvenile rheumatoid arthritis. They were, say, a 16-year-old female who was on methotrexate, their birth control, because, again, methotrexate's category X, pregnancy category, it's an abortifacient, so you definitely don't want them getting pregnant while on that. So let's say they're on oral contraceptives and they're on methotrexate, and it's working well for them for a while, but then, maybe their symptoms are not fully controlled, so they could put it on Actemra as well. All of a sudden, that Actemra starts to induce 3A4, and all of a sudden, they're metabolizing their birth control more quickly, levels of estrogen drop, and their risk for ovulation increases. So now all of a sudden, you can have an accidental pregnancy with someone who's on methotrexate. Great. So again, this is why you got to do your checks. Make sure anytime you're introducing a new drug, see what interactions are going to be there. It takes you, 2 minutes to look for the interaction, and that could potentially save some huge adverse effects down the road. So again, do your due diligence, right? All right. So with the biologic agents, you can find that patients will either have what they call a primary lack of efficacy, where basically you fail to see response within 3 to 6 months or so. For some patients, they'll have what we call secondary lack, where the drug looks like it's working initially, but then all of a sudden the efficacy starts to dip down. You're like, what's going on here? Some of this is related to the body developing antibodies against these biologic agents, right? So just like we talked about before, sometimes by using a non-traditional or using a non-biologic DMARD like methotrexate can help to inhibit that. That's why that combination can keep some of these biologic agents working for longer. Is tocilizumab tritogenic? Not to my knowledge. IL-6 is not really all that important for use in fetal development. I can look it up real quick though. So if we were to look over here in our handy dandy lexicon, we can see. I'll look here. And so pregnancy categories are kind of fraught. We'll talk about that later. But one of the things we'll see is that reproductive considerations. Based on limited data, tocilizumab may be considered for use in women with rheumatic or musculoskeletal diseases who are planning a pregnancy. Treatment should be discontinued once pregnancy is confirmed. There you go. So yeah, like I said, I wouldn't expect this to be directly tritogenic just based on this mechanism, because fetuses aren't normally causing a lot of IL-6 to be produced, or they don't really require it, so they should be fine on that standpoint. Anyway, so next, talking about corticosteroids, these are sort of going to be meds you're going to require for a lot of your patients here with RA. You're going to find that they are good as an anti-inflammatory. They're going to suppress that immune system, and all the side effects that go along with that. We know there's a ton of them, but overall, these are going to be good for both. There's a couple different ways we can use them, right? So you can use them chronically. We can use them every single day for patients to help control their symptoms. And the ideal thing would be to not do that if you can, right? The fewer patients we have on corticosteroids chronically, probably the better, but some patients require it. So getting down to a low dose as possible is going to be beneficial here. Other ways we can do this include for bridge therapy. So that's where I mentioned if it takes, a month or two for your methotrexate to kick in, utilizing corticosteroids in the meantime to help bridge that gap of efficacy can be useful. So that's why we call bridge therapy. And then for patients having like an acute flare-up, we can utilize corticosteroids as well for that. So you'd have kind of like a pulse dose. We're going to get a big dose for a couple of days or a week or two, and then you titrate back down to what their normal would be. Okay, so that's one way you can do it. In terms of intramuscular administration here, you can use it for either short-acting or burst therapy, but frequently you may see from a compliance standpoint, we utilize long-acting depot forms. That's where you have a form of a drug that's injected into the muscles, usually in like an oil sort of base, and a lot of times, and it slowly leaches out the drug into the bloodstream. It lasts for months usually. So if you ever see like a depot medrol, that's going to be methylprednisolone in a depot sort of form there. The other benefit with this too is it has sort of like a nice long natural taper over time. So if you recall, one of the big challenges with corticosteroids is that it shuts down your own production of cortisol. So if you have someone who stops taking their corticosteroids, they've been on it for months, they stop at cold turkey, they can have adrenal insufficiency and go into adrenal crisis. For something like a long-acting depot form, those levels naturally drop off very slowly, so it kind of gives your adrenal glands time to pick back up production as levels start to dip down. That's one benefit there in case you have a patient who's non-compliant, doesn't come back to the office to get their shot, whatever the case may be. Another way we could do this would be to go to the site of inflammation directly and go into the joint itself. So you have these intra-articular injections. And again, this is something where you want to make sure you're doing this under a sterile field because the joint is kind of a protected site. You don't want to introduce any pathogens into there. But this is good for patients who have maybe like a small number of joints being affected, maybe one or two. And the benefit here is because the joint itself is pretty much encapsulated, it limits the systemic activity of the corticosteroid. Not a lot of it gets out and can affect the rest of the body. One negative thing here is you can only use it a couple times a year because you're going to find that if you use it more often, it can actually lead to things like tendon atrophy and increased joint destruction. So not great from that standpoint. Ideally, lowest dose possible should be used here. We do know that it does cause some degree of disease progression. It will limit that to some degree, but really the big things we need to do is get the DMARDs on board. And ideally, we're going to use the lowest dose possible, as I mentioned, because all these other adverse effects are going to happen here, especially in older patients with rheumatoid arthritis, risk for osteoporosis, cataracts, hyperglycemia, hyperlipidemia, more on top of that, further infection risk in addition to all their other biologics and traditional DMARD. So again, good for what they do. They're very effective, but a lot of caveats with that, right? And NSAIDs are also going to be used. This is probably going to be pretty chronic therapy. This does nothing for a disease progression, but it only helps out with the inflammation. It's more for symptomatic management more so than anything else. But you'll find the patients will be on these chronically. Again, consider, and we talked about this in the last section here, the different NSAIDs in terms of comorbidities and things like that will lead you to pick one drug versus another. So kind of getting into the NSAIDs. For rheumatoid arthritis, it's like cornerstone of therapy. Everyone's going to be on some sort of NSAID therapy, right? For osteoarthritis, it's probably going to be used as an adjunct to things like acetaminophen, or you may see them used by themselves. But again, they're not going to do anything to modify disease progression for these patients here. You may find patients will have variable responses to these drugs, and so it's okay to switch between different NSAIDs to see what they're going to be tolerating or what works best for them. We're going to see that, there's no real use for combining NSAIDs here. If you have someone who had cardiovascular risk and they needed low dose aspirin, that's okay to use in addition to an NSAID, but no other benefits of combining NSAIDs here. But if you recall, one of the big things to focus on is the COX-2 inhibition issue and the risk for GI, peptic ulcer disease, basically. So if a patient has a high risk for GI complications or has a history of GI complications, you want to go with a more COX-2 selective drug like celecoxib or meloxicam. Those are probably the two big ones you're going to want to use there. If they don't have that history of GI risk or low GI risk, then you can use a non-selective NSAID. That's perfectly fine there. But really the COX-2 inhibitor should be reserved for those more high-risk GI patients, right? So if they have a high risk for cardiovascular disease, I would probably say if you can get away with using a non-selective NSAID, it's probably going to be good, because if you recall, we talked about if you block only COX-2, there's a risk you could have, like Vioxx, you actually saw increased cardiovascular death. We don't see that same risk with things like celecoxib, but there's a theoretical concern. So some people feel if you have to do that in someone who has a high cardiovascular risk, previous MI, things like that, use a non-selective NSAID plus a gastroprotective agent. So either misoprostol or PPI or something like that to try to limit that risk for developing a peptic ulcer. So kind of thing to consider. So really low risk for GI complications, use non-selective NSAID. The high risk, either use a non-selective NSAID plus a gastroprotective agent or a COX-2 inhibitor like celecoxib or meloxicam. Those are two best options there. Okay. So here's kind of the algorithm for how you would end up treating these patients here. So if you had someone who is kind of naive to DMARDs with rheumatoid arthritis, you want to start off with something like methotrexate, most likely for most patients, unless it has some contraindication. And then you'll kind of do plus or minus prednisone to start with, depending on what their symptom severity is like. If it's very mild, they're not really all that bothered by it, then you don't need the prednisone, but a lot of patients will need this to bridge the gap. Once you get up into sort of higher stage activity here in terms of disease severity, you're going to find you can either you can try to switch out of the methotrexate and use something else as monotherapy, or go with combo therapy. Traditionally, most people will go with a TNF alpha inhibitor plus or minus methotrexate. That seems to be most common. However, some people may want to go with something like Actemra plus or minus methotrexate. Nowadays, now that we have Tofacitinib, the JAK inhibitors, that's also another alternative. That's something we could use instead. Okay. So, or you could also do methotrexate plus another traditional DMARD. Okay. A lot of options there. But remember, when you have so many options, what makes the difference? How do you decide which one you're going to go with? Well, consider what the comorbidities are. Consider other drugs the patients are on, etc. So, for instance, if I gave you a test question that said, patients on methotrexate, it was working well for a while, but now the disease has progressed and now they need something else. Which of these options may be good, or is the best option for this patient to add on? If I said something like they have a history of CHF, well, something like Infliximab is probably not a good option for them, right? Or if I said they're on a drug that's metabolized by CYP3A4, well, maybe Actemra is not going to be a good option for them, if they need to be on it. So those are little things to consider when you have so many options available to you. Consider what the contraindications are, consider what the comorbidities are, etc. That will lead you to choosing one versus the other. Okay. If they have a non-TNF biologic failure, that's where you can try to add on something else, a different category there. So, if they failed Actemra, well, maybe try something like Tofacitinib, right? Try to switch your mechanisms there to see how they're going to do. If they have just a single TNF alpha failure, I typically see a lot of people, they won't necessarily switch within TNF alpha inhibitors. So if they fail Infliximab, I don't oftentimes see them go to Humira. I usually see them try to use a different mechanism. So something like abatacept or tocilizumab or something like that. So, and again, a lot of this probably sounds like gobbledygook because everything ends with a mab. That's why I got to go back through and review that and make sure you understand which ones are doing which mechanism there. So hopefully that makes sense. Basically, if something's not working, try switching up the mechanism. That's pretty straightforward. So as I mentioned with combo therapy, remember that non-biologics you can typically mix together pretty well together. No big issue. So methotrexate plus hydroxychloroquine, totally fine. I probably would not use methotrexate plus leflunomide because the risk of hepatotoxicity is pretty high. So I'd avoid that combo there. But all the other ones are totally good to go. For your traditionals plus biologics, any of these are fine. You can mix and match any of these two here. I didn't really talk about anakinra, so don't worry about that one. But any of these other ones, totally reasonable. These are just examples. This is not the only ones you can do, but just something to consider. But do not mix two biologics together, okay? Don't mix tofacitinib plus a biologic. Again, too much immunosuppression. I would not do that either, okay? Okay, let's see here. So switching gears a bit and talking about, and I apologize, I seem a little distracted. It turns out one of my cousins, his wife just went into labor this morning, so I'm watching the family text feed. So I apologize. It's very unprofessional of me, but it's a big deal. It's a a bit of a sunshine and an otherwise bleak existence that we all suffer through here. But anyway, switching gears and talking about acetaminophen briefly here. Kind of switching from RA over into osteoarthritis treatment. Typically, acetaminophen is going to be kind of the first thing you're going to try for a lot of these patients with osteoarthritis, although its overall efficacy is going to be limited, especially as time goes on and the pain's getting worse. And, for instance, if you had a patient who's coming in, say, to the urgent care, and they said, oh, my back is like killing me, I have this, or like their hip is killing them, they have this awful osteoarthritis, and they're, you try to give them acetaminophen, they're probably going to laugh at you. They're going to be like, that's not going to work. Come on, right? So for more mild to moderate cases, acetaminophen may be useful here. Overall less effective than the NSAIDs, but less toxicity. And we talked about acetaminophen, so we know the risk with that. Hopefully that question on the quiz made some good sense in terms of making sure not to exceed your maximum amount of acetaminophen, usually 4 grams for most patients there. But the other thing here, relatively safe. That's really the big benefit. So well tolerated, but less efficacy. The cool thing you can do for patients with osteoarthritis, especially if it's a relatively few number of joints, is you can utilize topical analgesics here. So we mentioned these briefly in the pain management section, but these are good, especially if they have their left knee kills them, right? Maybe they're an athlete and that was the knee that got all the wear and tear, for instance, or something like that. Or these are good for patients who maybe giving NSAIDs to those greater than 75 is not going to be preferred because of risk of like renal toxicity and GI toxicity, etc. But because we're using topical, the systemic effects are going to be pretty limited. Because we're going to get into like Voltaren gel, we mentioned is over the counter now. Aspercreme, which is a salicylate based cream, those are all fine there, and those have pretty good efficacy. Again, using topical products, probably not as preferred as a tablet or something, right? But it is still a reasonable alternative. Capsaicin, really good for these patients here by depleting that substance P. But again, it's uncomfortable to use it first, right? But over time, you're going to find that it will, if they use it consistently, it does work pretty well because it keeps those painful fibers from getting sensitized by that substance P there, right? You can also use other things like counter irritants occasionally. So things like menthol and camphor. These are kind of over-the-counter products you'll find out there. Basically, it creates this sort of this surface where it can kind of draw the pain away, so to speak, because it kind of acts as an irritant at the skin, either by causing cold or a heat sensation. Maybe distracts from the pain signal. It's limited efficacy, but it's something you can try. So it was like when my dad said, I said, "Oh, my foot hurts." And so he stepped on my other foot, and I go, "Ow, that hurt." And he goes, "There you go. Forgot about the other pain, right? I already fixed it." He's a great dad. I'm just kidding. He didn't really hurt me, physically. But anyway, you can also utilize intra-articular corticosteroids for patients with knee or hip osteoarthritis as well. Same caveats go with this as with RA, is that you don't want to use it too frequently. Probably not more than every 3 months. 2 to 3 times a year is probably the sweet spot for a lot of those, right? Opioids, I would try to limit these as much as possible for osteoarthritis because, again, OA is a chronic problem. Opioids are good for short-term issues. However, a lot of patients are going to get started on chronic opioids for this. And so that has all those risks that we know about, the tolerance, physical dependence, the addiction risk. It's not great. So again, fewer opioids are going to be better in the long term for these patients here. Because ultimately, what's the problem with the patient, right? Their knee is worn out and needs to be replaced. So not every patient is going to be, capable of getting surgery, but they can get definitive therapy. That's going to be much better than them being on opioids for the course of months and years, right? Okay. Something else you could do for patients with osteoarthritis is this is actually a dietary supplement called glucosamine and chondroitin. I don't talk about dietary supplements a lot, mainly because, I don't have any particular prejudice against them. I think they can certainly be effective in certain situations here. But the main problem you run into with dietary supplements, I don't know if I've mentioned this before, is that they're not under the purview of the FDA, right? So when you go and buy a bottle of acetaminophen and it says 500 milligrams per tablet, the FDA regulates that, and they have that's going to have 500 milligrams. That's just what the way the system works, and it's definitely you can be guaranteed that has 500 milligrams. For dietary supplements, there is not as tight control over that stuff. So you can have various brands of glucosamine and chondroitin, for instance, and they may say they have so much of each product, but that may not actually be the case there, right? So this is why you want to make sure if you're going to be recommending dietary supplements to patients that they get reputable brands. There are some organizations out there that do testing for these, make sure they have a good standard of practice, but it's not regulated through the U.S. government. So there's not going to be as quite of a strong confidence in that as you would have as if it was the FDA, right? So we're just going with the assumption that the FDA is doing all their work and making sure that everything is done perfectly. May not be the case, but that's the assumption. So that's why I tell patients if they're going to go for a dietary supplement, make sure they get a reputable brand and stick with the same brand each time because they're more likely to get a consistent effect out of that. So that's what I would say with that. Now, glucosamine and chondroitin is interesting because this is products you find in your joints anyway. And so this is thought to help out with like things like proteoglycan synthesis and help out repairing some of the cartilage there. You're going to find that it has pretty moderate effects. It's not going to do anything to like, stave off a knee replacement, the need for one, but it can certainly help out with some symptom management and may help to maybe slow down wearing of the joints over time. It's also relatively safe, which is good. And so basically, it's one of those things where the big organizations like the ACR, they don't have any specific recommendations regarding it. It's one of those things, well, if you want to try it, go for it. If you get some benefits, good. If not, well, then don't take it. It also carries a shellfish allergy warning. So if patients, I think it's the chondroitin aspect of it. I can't remember. I always forget. It's either one of those two. One of them has comes from shellfish, and so if they have an allergy to that, it could cross-react. So you would want to be cautious if that's in the patient's history there. Another option here for patients with osteoarthritis includes hyaluronate injections. This is basically injected directly into the joint to kind of replace this constituent of that synovial fluid that they are missing. And it also has some anti-inflammatory properties too. So it kind of helps out, helps with the symptoms of pain, helps with some mobility there, and is usually given every 3 to 5 weeks or so. Now, some people get confused and they say, well, wait a second, this is every 3 to 5 weeks. You can't do that more than 2 or 3 times a year, you just said. That was for corticosteroids specifically. With the hyaluronate, you can do it more frequently, and it's not going to be really a problem for them. And it's also relatively free of side effects, other than maybe some injection site pain and potential infection if whoever's injecting it did not do a good job keeping things sterile. But anyway, so what's the flow, kind of the algorithm you would do with this? Well, let's say we have someone with hip or knee osteoarthritis. Basically, it's okay, they require pharmacologic therapy. Can they use acetaminophen? Is it contraindicated? If no, then go ahead and start out acetaminophen, max of 4 grams a day, right? Assuming they don't have any hepatic disease or anything like that. If they cannot get that, then you want to start to consider things like topical NSAIDs. This is better for knee osteoarthritis. With the hip, it's kind of difficult for it to penetrate that deep for it to really be all that effective. But for the knees, certainly this can be really good. You can also consider things like intra-articular corticosteroids. Tramadol is sometimes recommended as an alternative to opioids since it's only partial opioid agonist, and or you can get away with oral NSAIDs, especially if they have, they're less than 75 years of age, if they have relatively low cardiovascular GI risk, things like that. So is the treatment effective? If not, then pretty much if they fail acetaminophen, they're probably going to start to go down this other route of topical NSAIDs and things like that. Other alternatives can include things like opioid analgesics, surgery, intra-articular hyaluronate injections, all that stuff. So if I had a patient who I said, they had knee osteoarthritis, their left knee that was really painful. They were trying acetaminophen, but it really wasn't working for them. What's the next best option for them? I would say probably a topical NSAID could be a good option because there's only one joint that's being affected. They failed Tylenol, so let's try that out. Okay. If I said, they're, have osteoarthritis of both hips bilaterally, both knees, using topical NSAIDs may not be the best option for that, right? You may need more systemic therapy at that point. So then you can consider, and if I said, they're 85 years old, well, an oral NSAID is probably not going to be a good option for them, for example, right? So kind of look at all the factors there. This is where, this point in the semester, we're getting more so into not just memorizing how a drug works necessarily, but like, well, who's it going to work best in? Who is it not going to work well in by looking at the patient factors? Do they have diabetes? Do they have, how old are they? Are they at risk for becoming pregnant? All these different things you got to consider when looking at these questions here. And because that's what you're going to do when dealing with patients, right? You're going to look at the whole picture to see what's going to be most appropriate based on all these factors here. Okay. So then looking at hand osteoarthritis, this is a little bit different because unfortunately you can't get like a hand replacement, at least as far as I'm aware of. But looking at patients, if they are less than 75 years of age, you can get away with using oral NSAIDs. You can try topical NSAIDs, capsaicin, tramadol, any of that's fine to try there. Typically, they're older, so greater than 75, you would probably skip the oral NSAIDs if possible, because of renal and GI risk and things like that. If it's not effective, then you can consider using like combo therapies at that point. So it's kind of mixing and matching and trying to figure out, okay, what's going to work best for them, basically. So a little more challenging with hand osteoarthritis, but you try to do the best you can. Okay, so any questions on that material there? Trying to see where I'm at in terms of schedule. I know I'm behind schedule, but I'm really behind schedule. That's okay. I'll definitely be able to catch up. So I'm going to use a few more minutes if you guys don't mind here, just to start talking about this. So just switching gears here a little bit, but looking at osteoporosis and osteomalacia, just because we're kind of missed 30 minutes from the quiz, so I just want to talk for a little bit later. Anyway, so because we're already talking about, the joints, let's kind of move into talking about the bones here for a little bit. Basically, this is a disorder where we have low bone density. This is usually going to be due to an imbalance between laying down bone by the osteoblast and taking up bone by the osteoclast. And overall, why we care about this is because low bone density is going to lead us to be more predisposed to fractures, which is not great. If you have an older patient who has a vertebral fracture, a femur fracture, this can be almost a death sentence to them because it is going to be increasing the morbidity. They have issues of mobility, all kinds of problems. They just kind of spiral, and you definitely see a big change in quality of life and also the quantity of life in a lot of times in these older patients. I'm not going to go over every single medication out there that can affect the bones and cause osteoporosis, but just a few that I highlighted here to think about, because we've kind of talked about some of these already, are going to be things that you want to look at the medications that are on to figure out, okay, is this something that could potentially lead to osteoporosis? Big ones, corticosteroids, right? Because we know that it's going to decrease our bone mineral density. We know it's going to increase that risk for fracture. This is huge. So if you have someone who's on has rheumatoid arthritis for a long period of time, they've been on corticosteroids for years, their risk for osteoporosis is going to be much higher and risk for fractures. You got to keep that in mind. But even things like proton pump inhibitors, right? We talked about how PPIs decrease calcium absorption. So if you have less calcium in the blood coming in from the GI tract, where's your body going to get it from? It's going to suck it out of the bones, right? That's just the balance and how it works with PTH and all that stuff. And then the other big thing you're going to find here too, especially with older patients, is that estrogen and testosterone have strong effects on bone mineral density, right? Estrogen especially. So this is why when you have patients who are postmenopausal who are not producing their own estrogen anymore, or if you have medications that prevent them from forming estrogen, that's going to be a problem, right? So there's a set of drugs called the aromatase inhibitors, which actually prevent the conversion of testosterone over into estrogen. And that can lead to deficiencies of estrogen, which lead to, again, decreased bone mineral density and risk for osteoporosis. But we will talk about some of these as we get to them. Obviously, we talked about PPIs and steroids already, but we'll talk about the aromatase inhibitors as we get into the OB-GYN section later on. But just know, many medications out there that can potentially affect the bones, and you want to take that into consideration when looking at a patient's medication profile, right? Anyway, so looking at this, you're going to see that the bone resorption, or the taking of calcium out of the bone, is done by the osteoclast. The bone formation is the osteoblast. There needs to be a balance here between the two in order to make sure the bone mineral density stays relatively the same. We're going to typically find that estrogen and testosterone will increase bone mineral density by increasing the activity of the osteoblast, which is again why you see deficiency of these as patients get older. The risk for osteoporosis goes up, but also parathyroid hormone. Parathyroid hormone is going to be very important because if the parathyroids detect low levels of calcium, it will release parathyroid hormone to try to get that calcium out of the bones. It'll also try to help reabsorb it in the kidneys, try to increase the reabsorption or absorption from the GI tract, but the big place is going to get is from the bones. And so when we have this disbalance, we're resorbing more than we are laying down, we're going to get these weak, brittle bones. So calcium homeostasis, and again, I'm going to try to get the baseline down here so we can get into it next time. With calcium homeostasis, this is maintained by vitamin D and PTH, okay? Having both of these is going to be affecting how well we're going to be absorbing calcium from the GI tract, and then also how much we're reabsorbing from the kidneys, because the kidneys is the main place you're going to get rid of calcium. Keep in mind that when I say vitamin D, there's a lot of forms that are out there, right? So you have forms that you get in medicinal products or like in food. There's things called cholecalciferol. There's ergocalciferol. That's not the active form of vitamin D, okay? The stuff you make in your skin when you go out to the beach to stay socially distant away from people and you get a nice suntan, that vitamin D is not the active form, okay? It's inactive form. What you need to do is it has to go through the liver and it has to go through the kidneys in order to become activated. When it goes to the liver, it becomes maybe 25 hydroxy vitamin D. And then when it goes to the kidneys, it will then become the 125 form. This 125 dihydroxy vitamin D is the active form. Another name for this is calcitriol. Okay, this is the one that is going to be useful to us. So this is why you have patients who have liver dysfunction or renal dysfunction. They can't make this vitamin D form. And they can't regulate the absorption of calcium from the GI tract and the kidneys unless they're at risk for osteoporosis. Okay, so just keep that in mind. 125 dihydroxy vitamin D or calcitriol is the active form. Just go by going out into the sun does not mean that's enough to get active vitamin D, right? You got to have good organ function for that to happen too. So anyway, low calcium levels are also going to stimulate parathyroid to release parathyroid hormone, and that's going to stimulate bone resorption from the kidneys. That's going to be stimulating it also to stimulate osteoclast activity from the bones as well. Okay, so you're going to get more calcium being sucked up back from the kidneys, so that way you don't pee it out. And osteoclast activity is also going to be increased as well. Okay, and so estrogen deficiency is also going to be increasing the osteoclast activity additionally. Okay, so that's why you see patients for postmenopausal develop osteoporosis most likely. So our goals for these patients, it's obviously we want to try to maximize our bone mineral density and try to make sure that we keep bone mass and strength up and prevent fractures. That's really the biggest thing. And then if a fracture has occurred, trying to prevent future issues from popping up, trying to increase their quality of life, functionality, and all of that, right? So in terms of like non-pharmacologic therapy, this is where things like calcium is going to be huge for supplementation. Keep in mind, though, that there's all kinds of side effects associated with constipation, nephrolithiasis, that they have a history of that. And also they need to separate this out from other medications that may bind to it. Okay, bisphosphonates are a new class we're going to look at here in just a little bit. And then vitamin D, as I mentioned, is going to be required. A lot of patients are going to require exogenous supplementation, especially like things during the winter months when people are inside more often. Less of a problem in Florida, but depending on where you work. And keep in mind, you have to have active vitamin D, so it has to go from the intake, whether it be from the skin or from the GI tract. That's usually the ergo, the cholecalciferol form. Then it has to go in the calcifediol in the liver, and then calcitriol in the kidney. So it has to go through the two-step process. If you have poor liver function or poor kidney function, you're going to be out of luck. And so that way we have to supplement that and actually give calcitriol exogenously. So we'll talk about that a little bit later as well. So in terms of the medications we're going to need here, typically we're going to find is that for a lot of women and men who are older, they're probably going to require some kind of therapy here in order to treat osteoporosis. And again, we're going to find that as their bone mineral density gets lower, their risk for fractures is going to go up more and more. And so this is how it kind of guides your therapy by doing your DEXA scans and all that stuff will kind of guide you into choosing how strong a therapy you're going to need, right? So that's where we get into our anti-resorptive therapy, right? So we talked about calcium, vitamin D already. We're also going to get into some other drugs here, things like your bisphosphonates, some estrogen-based drugs, calcitonin, things like that. So we'll get into those medications here a little bit later. So I think I'm going to go ahead and cut it off there. Let you guys have a little bit of a break. So if you have questions about the quiz, feel free to send those over to me. Otherwise, I'll take a look at the stats and see if there's any issues there, any high misses or anything. But any questions from you guys? No sticky board activity today. That's sad to see, but that's all right. Any other questions I can answer for you guys before I let you go? Well, if not, you guys are free to go. I hope you have a wonderful day, and I will see you all next week. Yeah, you guys have a great weekend too. Class is at 9 next week. Let me check. I don't know. Not to my knowledge. You guys have another test? Why'd I put 9 to 10 on there? Let's see. It should. I think it's from 8 to. It should be 8 to 10. I'm not sure if that got goofed up somewhere. No, we don't have. Yeah, it should be 8 to 10. I'll update that on the. I don't know how that got missed. No, I need that 2 hours. I can't be letting you guys get off an extra hour. Come on, it's ridiculous. All right, thank you for pointing that out. That was a oversight on my part. All right, you guys have a great weekend, and I will see you all later. Don't say darn. These are good classes. You're paying a lot of money to take these classes. You got to get every hour you're entitled to, right? All right, I'll see you guys later.